we were better and we were cheaper. And in what other industry are you just not covered up with business if you're cheaper and better?
Right.
This is America, for God's sake.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. But, you know, we just had it not too long ago with my son, and he just went in and he was having trouble breathing. I've got a 3-year-old boy and a 7-year-old girl. And the 3-year-old, he was just wheezing. He's had his tonsils out. He's just always had issues with his nasal passages. And so one night he woke up, and I think he scared himself too, and we just couldn't get him to calm down. So my wife took him in. It was probably 2 or 3 in the morning. And, you know, we got a $3,500 bill because it was a level 4 ER. And we're like, I mean, I know enough to know that we're not going to pay that. But
that was not a level 4 either.
Yeah, right. But that's what they charge us for.
Sure.
And that's one of those things that Marshall talks about as an obvious, they'll just upcode whatever.
It's upcoded.
What do you think it should be, in your opinion?
Well, and the market's answer to that is happening in the United States. And one of the examples in Oklahoma City is a group of disgruntled emergency room physicians who were tired of aiding and abetting crimes like that.
Yeah.
Got together and formed an emergency room hospital.
Okay.
It's physician owned, and their pricing is tiered.
Okay.
And they have a price for 1, price for 2, price for 3, and a price for level 4. And you know what it is when you walk in.
Right.
And what you just described is
he had a breathing treatment, I think, is all they gave him. Yeah.
You're describing a level 1-ish to, it would have been $400.
Yeah.
For the whole thing, cash. And so, the market, if allowed to respond, will fix stuff like that. And then word will get around. And even if hospitals get away with a few shenanigans like that, eventually their reputation is so tarnished that no one goes there because they might as well just have spray painted price gouger up on the side of the building.
I look at just the general immorality of that. Just hearing you describe it, right? It's like, how can you justify it? And if so, if they get called out, do they simply pull back and say, "Oh, we're sorry, that was a mistake," or whatever their excuse? Yeah. But then you're doing that intentionally.
Well, yeah.
And how often is it done?
And there are two models in the industry. One is, how do I generate the most revenue? Mm-hmm. And that, unfortunately, is the prevailing model in the United States, is what do we do to increase market share at this hospital? How do we generate the most revenue? Mm-hmm. How many revenue cycle management vendors are out there? I mean, that's how do we generate and keep our paws on all this revenue? The other model is, how do I deliver exceptional value? And that's the model I champion, where it's a mutually beneficial exchange. A $3,500 bill for a wheezy 3-year-old, that is not a mutually beneficial exchange. That is not, we can't wait to go back to that facility when the next thing happens. Right. That's a hit and run.
Yeah.
I'm a golden rule mutually beneficial exchange person, and we have a lot of repeat customers. And I always ask people, did you shop around? Did you get a price before you came here? And it's usually 8 or 10 to 1 if they can. But people do that. They price gouge because they can. And for them, it's all about the revenue. And that's why I'm also a champion of physician ownership, because if a patient asks their physician, who is a hospital employee, can you help me with this bill? The answer is no. They have nothing to say. If a patient asks a physician who owns the surgery center, can you help me with this bill? The answer is yes, I can do everything about that bill, including make it go away.
Okay.
And that was the model before the government messed everything up in the early 60s. Most of the hospitals in the United States were owned and controlled by doctors.
Okay.
And they individually, one-on-one, addressed and accommodated hardship. And then you invent this thing called a not-for-profit hospital, which just means they don't pay tax. That's all it means.
Right.
But everyone thinks, well, yeah, now they're missional or they are faith-based. No, they're price gougers, almost without exception.
Wow. Well, I think that's a great way to start the podcast. So we'll just include that in there. That'd be a great segue. But I'll go ahead and introduce you, sir, so we can get this thing kicked off. I'm here with Dr. Keith Smith of the Surgery Center of Oklahoma. How are you, man? Thanks for coming on, man.
Thanks for having me.
I appreciate you kicking that off with a bang, man. I love it. Yeah, I knew we were going to have a fun conversation today. But before we get into your backstory real quick, I want to define, because I think the sort of the subject today, the overarching subject of the day, is this idea of bundled surgical procedures or bundled surgery in general. So what does that mean? If you could give us like a quick synopsis of what that topic is.
Yeah, bundled surgical procedures pertains to the price. And the best way to think about it is cash out the door.
Okay.
Or a price attached to a procedure that if that price is paid, the patient need not worry that there are any bills in the future forthcoming.
Okay.
So
it's an all-in cost.
It's
basically.
all in. Yeah. And for surgery, that usually means, not always, usually means surgeon anesthesia facility. So usually there are 3 components. There can be more. Those bundles are more complicated to construct and to implement. But we do it all the time. We've been doing it for a long time. But it's usually just 3 components. 3.
So you said it was the facility, the anesthesiology, and the surgeon in that. That's it, right?
That's right.
We'll get into why that's not the prevailing model, because it seems pretty darn simple to me.
It's pretty simple.
But I want to, before you became the famous, I think, Dr. Keith Smith and the originator, I think even we've perhaps used ChatGPT to prove. You said that you might have been the originator of this model. Let's go back in your story a little bit. Talk about where you grew up, where you went to school. I'd love to get to know you first before we go into the surgery center.
Okay. Well, again, thanks for having me. I'm Oklahoma, born and raised. My mother and father were both school teachers. My dad was an acclaimed choir director of some renown nationally. I came from a very musical family. Had an opportunity to go down a musical path as a pianist.
You did?
And
okay.
and I decided not to. And part of the reason was, like we discussed earlier, I grew up in a home where mutually beneficial exchange and the golden rule really meant something. And as a musician, while there might be entertainment value rendered to the recipient or the buyer, as a physician, that the potential for real value delivery dwarfs what I could have done really as a musician. And I had a choice. I could have gone either way.
Well, how did you develop an interest in medicine in the first place?
My brother had gone to medical school about 5 years ahead of me, and it kind of put that on my radar. And I enjoyed the sciences growing up, and enjoyed, talking to people. And so medicine went on my radar really when my brother went to medical school as an option.
What does he specialize in?
He's family medicine.
Family medicine, okay.
Yes.
And so did you look at what he did and say, hey, I think I want to kind of do that, but have a different specialty, or were you going to follow in his footsteps? What was the goal there?
I was actually a church organist at a large church in southwest Oklahoma, and singing in the choir were 2 cardiothoracic surgeons.
Okay.
And naive me, I said to them one morning, hey, I'm entertaining going to medical school. I mean, I was in high school.
Okay.
And one of them said, well, I'll see you at 7 o'clock in the morning at the hospital. So I wound up attached to the hip to this great man, his name's John Garrett, and he made me feel welcome anytime I wanted to see what he did. And when I was introduced to the environment of the operating room, I knew then this is where I belong.
Okay.
It's environmentally, culturally, a place that's not for everyone.
Sure.
But it was for me.
Yeah, that's what I was going to ask you because I mean, I don't want to say I'm particularly squeamish, but the idea, some people obviously immediately if they see, somebody cut open or the intestines or whatever the case may be, would go, I don't think I could do that. And I'm probably one of the people that falls in the category I can't do that. Apparently, you weren't deterred though. So, what is it? Just more fascination with the human body, or what?
Yeah, I think initially it's the ability to intervene in such an incredibly miraculous way to help someone get from A to B for
Right.
whatever their condition is, and just the incredible skill that was on display in front of me. As a musician, I was around world famous pianists and saw that incredible skill, and I don't know that the precision that I think my musical past brought to me was on display in a different way
Right.
by a cardiac surgeon.
Well, I'm glad you said precision because that's a correlation I definitely see between music and surgery. And obviously,
Absolutely.
dexterity with your hand, of course, and being able to think and be very precise in the way that you operate or cut or the musical notes. There's definitely a corollary there.
Yeah, absolutely.
So, do you play the piano anymore still? Just
I
out
do
of fun?
some.
Okay.
I don't play like I used to because I don't have time to practice like I used to.
Yeah.
But yeah, I play some.
Fair enough. So, where did you actually study, or where'd you go to med school?
I went to medical school at University of Oklahoma.
Okay.
Did an internship, kind of a rotating internship there at the conclusion of medical school, and then went to Little Rock, Arkansas to do my anesthesia and fellowship training there.
Okay.
So it was a great experience.
And when did you start practicing?
I started my private practice in 1990.
Okay.
I was 29 and much better trained than I had any idea, and just loved it from the moment I started. Was very busy right out of the gate. Had a couple of difficult cases early, like within the first week or two of my practice, that solidified my reputation with the surgeons that were in Oklahoma City, particularly at the hospital where I was working. And I got real busy real fast.
Well, that's awesome.
Yeah, it was awesome.
So you hit the ground running, and I presume you were operating within the normal sort of insurance model at the time, correct?
That's correct.
So when did you discover maybe some inherent inefficiencies with that arrangement? Right away, or
early on?
Okay.
So in 1992, Medicare paid me as a cardiac anesthesiologist about $1,000, $1,100 for the anesthesia services required for an open heart surgery. 1992 resource-based relative value scale, RBRVS, was inflicted on the physician community, where Medicare essentially attached a price to every physician service known to man.
Okay.
And they got them all wrong. I mean, they were either too high or too low. They got them all wrong because true pricing comes from competitive market activity, it's never imposed.
Well, why did they impose this pricing model?
Well, because they knew they could get away with it. And the physicians they targeted for the most damaging cuts were hospital-based doctors,
Okay.
radiology, anesthesia, pathology, and emergency room.
Okay.
Because if you're hospital-based, you just don't have as much say about your practice, about the demographics. You're a consultant, and
Okay.
so you respond when you're called on. So round one, RBRVS reduced that $1,100 payment to $500.
Really?
And then, not satisfied, those cuts were deep enough, they initiated part two, and the last heart I gave an anesthetic for, I was paid $285.
Okay. Wow.
So, and the last total knee for a Medicare beneficiary I gave an anesthetic for, I was paid $78. So,
Well, I don't know much about the
not
economics of
enough money.
anesthesiology, but that sounds like not enough money.
no, that's not enough money. I mean, everybody knows that's not enough money. So, I had fortunately read enough about economics at this point to know that this was not personal.
Okay.
These prices are are just signals. That's all they are. They're signals in the marketplace to clear the market. And they were sending me a signal, what they thought I was worth, and I thought it incumbent upon me to respond with a rational signal of my own.
Okay.
So I quit.
Okay.
They instituted price control, and I responded with a shortage of myself.
Yeah.
Because that's all I could do. And I didn't quit taking care of Medicare patients. I just quit filing claims. I just treated them as charitable cases because at $78, that's what they were.
Right. Yeah, absolutely.
And so my thoughts about mixing politics and medicine were formulated back in the early 90s.
Yeah.
And so simultaneously with this cut in physician fees, the hospitals began to grow.
Okay.
So hospitals then became grossly overpaid while physicians were underpaid. Mm-hmm. And inexplicably, hospitals became very aggressive with patients for unpaid balances, even as they were making all this money and the administrative staff was ballooning. And to continue to participate in that sort of world, in my mind, made me an accessory to a crime.
Yeah.
So I did what I had to do, and with another like-minded anesthesiologist, we walked away, and our practices were busy and lucrative, and we just quit. And we launched Surgery Center of Oklahoma because we thought as anesthesiologists, the only way we can have control over the patient's medical journey and also their financial risk is to own and control the facility where we work.
Okay.
And all the while the hospitals were making all this money, they were telling surgeons, we can't afford what you want to perform these cases the way you want to. So the quality of care really was affected by this RBRVS. I call it the Rosemary's Baby of healthcare. When it was born, it had exactly the effect price controls have.
Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments. Well, so then you spun off and started, you said, what year did you start?
97.
97, okay. And is that when you immediately were vocal about your pricing model as well, where you were showcasing that and using that as a lead magnet? Or?
It took about a week.
About a week.
So our mission was to provide the highest quality of care possible and for patients to always know what they would pay us before they arrived. Right. There would never be any financial surprises. And we also pledged that we would never accept a dime of money from government.
Yeah.
I'm very libertarian-minded, as you know, and the government doesn't have any money that it didn't first steal, and to take that money makes me the recipient of stolen property. So philosophically, we just could not go down that road, and we never have taken money from them. But the first week that we were open, and I've told this story so many times, but it's powerful. This young lady called, and she wanted to know, how much would it cost to have a breast biopsy there or a breast mass excision? And we're, high-fiving, this is why we opened. But I didn't know the answer to her question. So I put her on hold and I called the surgeon and he didn't know. Because I said, well, how much is your fee? He didn't know. So give me a fee or I'll assign one to you.
Right.
And he said, well, $500. And I thought, well, that's pretty reasonable.
Yeah.
I hung up on him so he couldn't change his mind. And then from my perspective, I knew that surgeon was going to take 20 or 30 minutes to do that case. So on the spot, I had to think through, what are my anesthesia services worth? You know,
Right.
the takeoff and the landing, 20, 30 minutes of my time. And I had a number in my head that I thought was fair. And then for the surgery center, I knew the supplies necessary to perform a procedure like this were minimal.
Okay. Okay.
And so I had a number in mind for that I thought would keep us in the black. And I was about to talk to her again when I realized she's going to want to know if she has cancer. So I called a pathologist and I asked him how much to examine this specimen. He didn't know. And he finally said $28. That's what Medicare pays me. So I thought, well, yeah, okay, that's not much money. So I took her off hold and I said $1,900. And she said, for what? And I said, for everything. She said, that's funny. The hospital down the road from you wanted $19,000 just for the facility. So when the case was over, I sharpened the pencil and looked at everything, and we made money.
Yeah.
And so our first week, we quoted a bundled package price over the phone, and then patients would call how much for an inguinal hernia repair, how much for a gallbladder removal, you know, how much.
You were kind of having to figure this all out as you go then, right?
De novo.
Yeah.
Yeah. How much my child has strabismus, how much to straighten his eye. You know, my child needs his tonsils out. You know, I need a total knee.
Yeah.
You know, and so we began to formulate a list of prices that were packaged prices. So when patients would call and ask for a procedure where we had already figured it out, we could just, here's an answer.
Just quote them, yeah.
And they couldn't believe we could actually answer them.
Well, as novel as it seemed in the 90s to do that, it still seems novel today to be able to do that, in my opinion.
That's right. If you just ask the surgeon, how much do you want? Invariably, the answer you get is very fair and affordable. If anything, it's too low.
Really?
Yeah.
So, okay.
You ask the anesthesia folks, what is your time worth? They push back, and then they finally come up with an answer. When you point out that, well, when a plastic surgeon asks you that, you give them an answer. Oh, yeah, that's right. I've got it based on 30-minute increments, and they give you an answer. And then the facility is just time and materials.
Okay.
The big hospital folks will say, well, we can't possibly know what to charge for the facility until the case is over. Well, if a facility has that much variability and uncertainty wrapped around any particular procedure with respect to whatever outcome is achieved, they probably need to consider not doing those procedures anymore, because some of these procedures can almost be commoditized.
Yeah.
They're very predictable. And if you're wrong and you need to pad for the uncertainty with some additional margin, do it. And then quote that price.
Right.
Yeah.
Right. Well, that's what you were telling me earlier over coffee. It's that the price is actually the proof of the quality in and of itself, right? Because you've created a repeatable way to do these procedures at a set price with still margin for you, and do it over and over again and be comfortable quoting that price, which by nature of the ability for you to quote it in the first place means you're going to have a positive outcome most of the time as well. Because if you were unable to deliver an actual positive outcome at that price, you have to raise your price, or it'd be proof that you weren't very good, right?
Well, we should stop doing those procedures.
Yeah, exactly.
Right.
Yeah.
And then if you're wrong, and you're consistently wrong 2 or 3 times on a number that in the past was right, then you just change it, and you change it moving forward. And an example of that is the pathology experience for a patient with a breast mass is very different now than it was in 97 when it was $28. Now there are all of these hormone assays and all of this very expensive stuff that has to be done to have standard of care on the examination of a breast mass if it's cancerous. And, those now are over $1,000. So we actually performed a couple of cases where we had not taken that into account. And so we ate it and adjusted.
And adjusted, right?
That's what you do.
Yeah, and I think just like anything, you expect a business to be able to operate profitably, and nobody's questioning whether you have the right to do that. It's just simply people want to know that they're not being taken advantage of. And I think, and we'll get into perhaps how that came to be, but I think knowing that there's a third party most of the time that's paying on my behalf in the insurance model, and they're negotiating behind the scenes in order to establish what should be paid, and I'm just at the mercy of whatever they've decided, it creates an inherently inefficient model for payment, which means inflation and means increased costs over time.
And it's a percentage of bill charges typically.
Right.
So the hospital is incentivized to gin up the charges.
Right.
And so then it just becomes wildly unaffordable.
Well, and so when you actually took the step at some point, I think you said it was 2009, where you started posting your prices on your website, right? Which,
yes,
again, very novel idea at the time, but in any other situation, it seems pretty obvious that your price would be a way that you generate market share, right? So you advertise a price for something, and that's how you actually win business. But in our world, in healthcare, that's a very uncommon practice. So what made you take that step to do that?
What led up to that was a legislative attack on the Surgery Center of Oklahoma and its business operations that actually was successful.
Okay.
That distinguishes it from all of the other legislative attacks that backfired on people who went after us and just cemented our reputation as an underdog and a champion of the poor in the community. In 2006, the insurance commissioner in Oklahoma allowed for a stacking of deductibles.
Okay.
So up to that point, a patient that came to us out of network could, and we were out of network with everybody because all the carriers hated us. If they came to us out of network, they could write a check for a package price that was less than their deductible. Okay. It was less than their in-network deductible most of the time. So it's very frustrating for the hospitals. And so more disparate deductible differences came about. You know, the in and out of network deductible then became bigger multiples of each other.
Yeah, yeah.
And that didn't work because our prices were still much, much, much lower than people's deductibles. So the insurance commissioner allowed for those deductibles to be stacked. So a patient had no out-of-network credit until they'd met their in-network deductible. So it emptied our waiting room because no one could then financially justify coming to see us. And it just about killed us. It just about put us out of business. And I still remember where I was sitting when I just thought in a market economy, if you're cheaper and better, and we were better. I mean, all the Division I athletes came to our facility. My partner Steve Lantier and I had anesthetized the children of all of the self-funded CEOs in the whole area. I mean, we were better and we were cheaper. And in what other industry are you just not covered up with business if you're cheaper and better? This is America, for God's sake.
Yeah.
So I decided I needed to put the prices out. Number one, so that patients with sticker shock could better find us wherever they lived. Number two, so patients could use our pricing to leverage a better deal if they decided not to travel to Oklahoma City for some reason. And then number three, because I was very naive to the scams that are at work in this industry, number three, I wondered if posting the prices would help us gain some insight into the various scams that were operational. And I would argue at this point, all three goals were achieved.
Okay. So what scams did you gain insight to out of curiosity?
Well, I couldn't understand why a carrier wouldn't want cheaper and better in particular. I mean, premiums paid in, claims paid out, the difference is profit. It's not that simple, turns out. The answer was that the higher the initial charge, the more money they make by repricing the claim. And so with me, that was an opportunity foregone because I was not going to give them a giant number to which they could claim their false, paste their false discount to. I also didn't understand that the arrangement between network carriers and hospitals was volume guaranteed. So if you bring us this much money, says hospital A, then you get a 60% discount. And if you fall below that threshold, then you only get a 30% discount. So the carriers couldn't afford to have me in their network at risk of losing this giant, discount at the hospital. So those arrangements are out there. And then, of course, the hospitals bill one amount, collect another, and claim the difference as money they lost.
Okay.
And that's the red ink that they rely on to maintain the fiction of their not-for-profit status. Yeah. And then to make that even more disgusting, they claim to the government that this is this lost revenue it's just so terribly gross and unfair that you need to help us. You need to subsidize us. So this animal called disproportionate share hospital payments, where the federal government basically kicks back a portion of what a hospital claims they did not collect. That's why the emergency rooms, while hospitals will claim are their loss leader, now all have a crane in front building on. Because even when a hospital claims they lost money, that uncompensated care is actually a revenue item. Okay. And I discovered that in a public forum one time when a hospital administrator, normally pretty close-vested, he lost his temper with me. And he asked me what percentage of my revenue was uncompensated care as a way to devastate, me. Yeah. And I didn't even understand that question. I thought, how can uncompensated care be revenue? Yeah. But it is. And when I started digging, I realized, yes, uncompensated care is that number they ship to D.C., and then Medicare pads their payments going forward to the extent that they claim these losses. So those are just some of the scams. And then, better than I do, I mean, some of the brokers get a commission for, based on, total claims. Well, the broker is not going to want any surgeries done at my place because that number is a reasonable number. It's not a ridiculous
Well, I think the most basic
number.
form of that is when you tie your revenue in the form of commission to the premiums themselves. Well, what do you naturally want to have happen? Just
go up.
By very nature, you want the premiums to go up. And I think when you look at all the players around the employer who have incentives directly or indirectly for the cost to go up, the employer is the only one that wants them to go the other direction for the most part. And it's unfortunate because the employer should be the center of the universe here, because ultimately all things are possible through them as the group purchaser, right?
Absolutely.
And so anyways, I could think you and I could go on a deep rabbit hole there, but I'll keep us out of.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
Did you salvage your business effectively once you started posting? Because it sounded like you were in jeopardy before. Once you posted online, tell me some of the net positives from posting your prices. Did you get an influx of activity after that?
We did. I was gambling that someone out there cares what surgical things, medical services cost.
Yeah.
And I was right. Right after we posted, Canadians started showing up.
Okay.
And they all have coverage, whatever. But they're in 3 or 4 or 5 year wait lines for basic procedures that are life-changing. The most common of which is a woman that needs a hysterectomy that's tired of getting transfusions every 3 months.
Jeez.
And she can end her nightmare for, I think our online all-in price is $9,000 for a laparoscopic assisted vaginal hysterectomy. And then uninsured patients started coming in from Oklahoma, not unlike the woman with the breast mass, just the word travels. And then uninsured patients started coming from other states.
Okay.
And then we got some national media attention for having done this from Reason Magazine.
Okay.
And one of Reason Magazine's biggest fans is John Stossel.
Yep.
And Stossel had me on his show twice. And then the other people at Fox saw that, and then NBC saw it, and ABC saw it, and we just wound up with all of this media attention.
That's incredible.
And it was actually my plan to promote this nationally first, because I knew the local media would not touch us because of the revenue they receive from the local hospitals and the carriers. And I was right about that. They wouldn't get anywhere near us until the national media exposure embarrassed them into, why haven't you reported on this, sensation right around the corner from you? And so then we began to get some local media attention. And I was self-funded at the time, and we self-funded in 99. And I thought, these self-funded employers have the same sticker shock that an individual buyer has.
Right. When
they find us, then we're not going to be able to handle all the business.
Right.
And I met Jay Kempton.
Yep.
He was preaching to his clients that as expensive as surgery is in the United States, everybody ought to go to India. And one of his clients in the audience knew me and set up an introduction. And Jay and I hit it off immediately and became fast friends. And the savings his clients have achieved over the years is just astonishing.
Yeah.
Yeah.
Do you think that partnership with the TPA that ultimately understood your business model and could funnel, if you will, or steer your direction, that had to help business, I presume?
It was transforming. And I wish there were more TPAs that would jump on board.
Because you tell me that's been kind of a constraint, which I was surprised, but then once you explained it, I wasn't. But it takes a special, really, truly independent type TPA to be able to shape around this model. So what are the limitations from a standard, if you will, third-party administrator?
I think that for a third-party administrator should approach their client, the self-funded employer, the same way an ethical broker does, where the only revenue the third-party administrator or the broker receives is directly from the client.
Yeah.
There aren't hidden revenue streams.
Right.
And I think that pressure is on the broker space, and that's why we're seeing so many good guy brokers, whether right out of the chute or they've changed their ways and have gone this way. And I think that pressure is on the administrator community, and I think we will see more of that. But it's hard for a real independent, honest, transparent, upright TPA to compete with a BUCA ASO.
Yeah.
Because they can say, we're only going to charge you $2 per employee per month, but it's because they're stealing it from you blind on the PBM side or other stuff. And when an honest TPA comes in and quotes a real price, it looks really expensive.
Yeah.
So those are the constraints I think that TPAs are facing. But we receive a lot of referrals from third-party administrators and from employers directly.
Yeah. Well, I want to go back to something you said a moment ago. You were self-funded back in 99, and I think you told me you were 20-ish employees around?
It's 24.
24, which is a really small,
That's pretty small.
Self-funded group. Was Jay your TPA?
No, I didn't know Jay then. This is back in 99. So we were with this outfit for a while, and we saved money.
But did you understand the whole idea of being self-funded at the time? Or, did you have to educate yourself in the world of employee benefits to even know this was possible as an employer?
Well, in my mind, I just knew we were paying Blue Cross $20,000 a month.
Okay.
And so I asked an insurance friend of mine, if I know my cash outlay is $240,000 a year, why can't I buy just a regular medical insurance policy for my staff with a $180,000 deductible, and I take that risk?
Yeah.
And if I win, I win. If I don't, I don't. And he laughed and said, that's self-insurance.
Yeah.
Let me see if anybody will even talk to you at 24
Yeah, that's what I'm saying. Yeah, I mean, it's hard to find people that are willing to help you
take the risk.
self-insure. Yeah,
and found an outfit that would do it. And they didn't do a great job, but they did a whole lot better job than I was getting for $20,000 a month.
Yeah,
so
no
we
kidding.
wound up saving money. And the employees that work at Surgery Center of Oklahoma, they have worked other places. And they know if I ever need surgery, this is where I need to have it done. So anytime one of our employees needed surgery, we just did it.
Yeah.
And so there really was very little exposure to the price gougers for my staff. And that's where a lot of the savings came from.
Yeah, I have no doubt. I mean, I think just unpacking that all and just looking at where the dollars are flowing, that's one of the things that I always talk about with employers that are new to self-funding is the majority of your spend today is claims, but you don't know where they're coming from. And you're not given any tools or any options to help control those claims. So once you open up that hood, maybe the biggest reason you go self-funding is now you actually have control over 2/3 of your plan spend, and you have the ability to get out in front of it or mitigate it, however you want to describe it. And so I just think it's fascinating that, back at that time and at your size, you were able to pull that off.
And the counterintuitive part was we saved money by relieving our employees of any out-of-pocket. And of course, the industry's done the opposite. They're trying to think, well, I want to lower utilization by jacking up what comes out of the employee's paycheck and jacking up their deductibles. And we went the other way, and we were right.
Well, no, I think you're absolutely right. It's when you incentivize human beings properly, they tend to make the right decision, right? And it's not, you don't force their hand. You just give them an option with clearly better incentives, right? And I think anybody that designs a plan with a $0 deductible and zero copay, it's just the right call. It's the opposite of where the industry has pushed most employers, which is to continue to erode the quality of the benefits as a sort of a knee-jerk response to the rising prices and the feeling that that's all I can do is make my employees' plan worse. Well, you can only make it so bad before you reach the limits of how bad a plan can be. Then what are you going to do after that to control costs? I think if you just remove that impediment, which is the dollar, to the person consuming the care that they need, they often will not only make the best choice, but you're probably getting it on the spectrum of that claim is going to be less severe in nature because they're going to the doctor when they need it rather than delaying care or letting the condition get worse.
That's right. And it's the job market's competitive right now in the medical world.
Is it?
And if you offer a benefit like that, you can hire who you want.
Yeah.
At first, it seems too good to be true. But once they realize, no, there really is a no out-of-pocket, complete wraparound approach to any health needs we need or our family needs, there's a real advantage that an employer has offering that to prospective employees.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
So Surgery Center of Oklahoma today, right? We talked about some of its origins, the overcoming of the potential for the doors being shuttered at one point. You guys do a lot more than I thought you did nowadays. You're describing all the procedures that fall under your umbrella. It's pretty extensive. I had my mind, it must be ankles and knee joints and things like that. But you cover a lot. So what all are you doing today, and how has your practice grown?
Yeah, we do ear, nose, and throat, and orthopedics, and gynecology, and urology, general surgery, oral surgery, reconstructive plastics,
Okay.
pediatric ophthalmology, podiatry. I'm probably leaving something out. We just added bariatrics.
Okay.
I'm sure I'm leaving something out, but it's a very wide range.
Yeah.
We also demand that any of our operating room staff have to be able to learn the skills to do everything. So we don't allow any specialization amongst the staff, which is challenging for them, but it allows us to schedule in an efficient way and not really schedule around any preferences that our staff have.
Right.
It's 149 surgeons now. It's a big medical staff.
How many patients flow through your doors in a given year?
It is real variable.
Okay.
It is a number that I would say is still recovering from COVID.
Okay.
But about 300 in a month is a pretty good month.
Wow. Okay.
Our peak was about 750
In a single month.
in a single month. That, however, was during the time, very brief, I'm proud to say, that we were in network with Blue Cross.
Okay.
One of our early self-funded clients went to bat for Surgery Center of Oklahoma and got basically forced Blue Cross of Oklahoma to contract with us.
When was this?
This was in 2015, 16.
And you said very brief though. So was it 1 year? 1 year? Or?
Yeah, they're like a cancer. I mean, they came into the office and they said, well, they're obviously there against their will. And I said, that's great. Here's our pricing. Oh, no. That's too complicated. We can't do that. You have to keep in mind, my pricing is on a single sheet.
Yeah.
When we send an invoice, and just here's what you owe us.
Yeah.
So we thought, well, what's the worst thing that could happen? We'll try it. We'll try to deal with Blue Cross and see how that goes. And it was a nightmare. Refusal to pay after we had even gone through the Mother May Eyes and after the care was delivered. Just horrible. And the surgeons felt like Blue Cross had to be part of their world because they were such a dominant player. And the surgeons loved it. I mean, they were bringing us all of their Blue Cross patients because we're so efficient. An ear, nose, and throat surgeon could do 15, 16 cases by 9 o'clock in the morning.
Wow.
So, they'd get all their Blue Cross stuff done and then get out of there. But we crunched the numbers, and we didn't make a dime. So we were in network for, I think, 16 months, and we did not have a dime of profit to show for that.
Yeah.
We had all these cases,
Yep.
but it was just a pass-through.
Yeah.
None of their pricing made any sense. I mean, they paid more for a tonsillectomy than they did for a tonsillectomy and adenoidectomy.
Okay.
They paid $745 for a complicated ankle fracture. That's to the surgery center. They paid $1,100 for a cochlear implant. Well, you can't do a cochlear implant for $1,100. So, again, these are signals that they were sending us that had we responded in a rational way, we would have said, that case belongs at the hospital to whom you pay 20x, what you would pay us. You're sending the signal telling us not to do this. I mean,
Right.
we were essentially dealing with an unwilling buyer and didn't realize that. And then we had to put some boundaries on what Blue Cross cases we would allow at our facility because they were so grossly underpaying us. And then we realized we can't terminate this contract or we'll have a mutiny from our surgical staff because they hate it too, but they hate it less if they do it at our place. And we couldn't figure out how we were going to get rid of
How did you exit that
this
relationship?
cancer.
then?
One day I got a letter in the mail that Blue Cross notified us they had terminated us.
Ah.
And it is posted on the wall of my
it
office.
framed?
One of the proudest moments. I closed the door and Steve Lantier and I hugged and high-fived.
That's funny.
And it was a great day. And they walked away, and it was only then I think I understood that it was the discount applied based to or in relation to the amount of money or patient volume to the various hospitals that triggered a less favorable price for Blue Cross from the hospital systems. That was at play.
Okay.
And so many of the surgeries were deflected and came our way. They probably just realized we got to stop this, and thank God they did. And I'm almost embarrassed to say we went down that path, but it was like a favor one of our new self-funded clients was trying to do for us. It almost seemed rude to decline it.
Yeah, that's funny. Well, so let me ask a big question here. Why is this model not the prevailing model? What is keeping this from being the norm in the United States?
Yeah, and as I said earlier, I think it's astonishing that this model exists at all. It's even more amazing that it is growing, but it's new. It's fairly new. The industry provides, the mainstream industry provides a lot of headwinds. There are a lot of people who make a lot of money to the extent that the system is dysfunctional.
Okay.
And they don't want that to end. And they have the ear of legislators and regulators who can make it difficult for change to happen. I think the money incentives are so wrong and are beginning to unravel, but I think it will take some time for those who profit from the dysfunction to be outed, and for people to acknowledge that I've been robbed, and these are the people who are responsible. And again, that's part of the reason I put the prices online, was to show that if you paid $42,000 for your knee arthroscopy, you could have paid $3,740 and had it performed by the surgeon who takes care of the Oklahoma City Thunder.
Right.
So,
well, when you draw that contrast, it's hard to justify the other one, right? It's like, how do you make an argument for the $42,000 payment, even if you think that's too cheap? You can't do it for $3,700. Okay, but how do you justify 10x the price?
Well, and the hospitals will say, well, we take care of all of these charitable cases and people who don't pay us, and therefore we have to shift the costs, to those who can pay. Well, if you look at all the cranes and the construction, if you take them at their word, I would say they've overdone it.
Yeah.
I would say they need to sharpen their pencils a little bit more about how much they need to actually gouge people. And of course, all that poor mouthing narrative is just theater. I mean, it's all lies. And again, once you understand too that if they claim they provided care free, they actually get paid for that through these DSH kickbacks. So they're not doing anything free of charge, and they're not paying tax. How would you like to not pay tax?
I'd love it.
Come on.
Yeah.
So you can't justify it. So
this is where the level, to me, it comes down to awareness of this model, right? Comes down to patients' awareness and employers' awareness, consultants' awareness of this model. But when we start to look at, and maybe we'll ask the question of, if I'm a consultant listening to this and I'm really interested in, how do I put this into motion for my group? So what do I need? What are the components of my plan? What do I need to look for as a potential impediment? Like, I know you work with consultants quite a bit too. So like, what would you say is a good group to consider putting in a bundled surgical model?
Basically, nuts and bolts. A consultant in consultation with their client can just ask very simply, who are the doctors and who are the facilities that you would like to work with? And then if the employer insists on buying in a direct, honest, transparent way, then the consultant's role would be to approach those physicians and clients and say, listen, employer X, who is a healthcare purchasing gorilla in town, wants to deal with you more directly in this way, you all wrap your minds around telling us how much you're going to charge.
Okay.
And that is so powerful because in 2009, when I launched the website, I had a tinfoil hat on my head. I mean, the idea that could or even should be done was crazy. And fast forward, you have presidents signing executive orders mandating basically what I did.
Wow.
So we've come full circle, or actually done a 180, I would say. And so if buyers, particularly self-funded buyers, put their foot down, then the world around them that provides medical services will change. The Free Market Medical Association is a great resource where a consultant could say, well, in my area, actually, there is a facility that posts its prices. There are direct primary care physicians. You know, there are options, and even starting in a small way is a good thing to do. And then this idea that employees are not willing to travel for medical care is just a myth.
Yeah.
We have contracts with employer buyers in 50 states, and they pay the cost of the patient and a companion, you know, and travel and lodging, no out of pocket.
Yeah, that's just it. If you're waiving the out of pocket for me and you're paying for my travel and lodging, and I know I'm going somewhere where I have a very high likelihood of a positive outcome.
Yes.
Why would I say no? Why would I say no to that?
And then once the local hospital or surgery center realizes that this employer in my town just paid for someone to go to Indianapolis, San Antonio, Austin, Oklahoma City, Sarasota, Florida, any number of other places St. George and Utah and Las Vegas, there are places to some degree like me all over the country. But once one of these black hats, once one of these price gougers hears that, that's scary for them.
Yeah.
And they will change their ways. They will bow down to the buyer. And the reason some people are members of the Free Market Medical Association and following this path is that they've been victimized by the market.
Yeah.
They have.
Well, and I'm glad you brought that up. I was going to ask you about the Free Market Medical Association. I'm familiar with it. I told you I attended one of the events years ago in Oklahoma at the Skirvin, beautiful hotel. But for those people that aren't familiar with what this organization does, what is the Free Market Medical Association?
So the Free Market Medical Association was Jay Kempton's idea. He had competitors who could not fathom how he was dealing with a maverick surgery center like me. And I had competitors who could not wrap their minds around how do I create package pricing and implement those bundles with a buyer like Jay Kempton or HealthSmart or whoever you want to name. And so Jay thought, let's give a run at putting the industry professionals together and make it center around buyers and sellers. And any intermediaries that are present have to be facilitators of that mutually beneficial exchange. And so that's how we set it up. And we have stop-loss carriers and ERISA lawyers there, and direct primary care is a huge presence.
Yep.
There's a big presence of brokers and consultants. And the organization now is in its 10th year. Our 10th annual meeting is this April in Oklahoma City.
Okay.
And, there's 37 state chapters now. And so Jay's idea was a good one. And it really does. It highlights the relationship between buyers and sellers and how when you do that and you eliminate the intermediaries that foul that exchange, what you end up with is an obviously mutually beneficial exchange, or one of the parties walks away.
Right.
So it's been educational for me and anyone else who's been a member.
Yeah, and if somebody wants to join a chapter, right? You said there are 37 states. They just look up Free Market Medical Association.
It's all there.
It's all there. Okay, yeah. Because I haven't attended one in years, and I know that there's some obviously that happened down in Texas. It's about time I get out to another event.
Go.
Well, so let's kind of move things towards the end, and I know you got to get it back on the road to Oklahoma. I always ask guests to sort of wax a little bit philosophic on where healthcare or this industry, this system, right? We keep going back to that word, the system. Where's it going, right? I mean, there's this general feeling, a sentiment that we're at some sort of precipice of collapse, change, I don't know what you want to describe it, with a lot of people suggesting that the involvement of the government might grow as a result of that. So what is your perspective on that? Like, where are we heading?
I think we're heading wherever the prevailing awareness will lead us, and that's why I was happy to drive down here to talk to you, because that's what this is all about.
Yeah.
If the American people are aware that every single thing that they hate about the delivery of medical services in this country is downstream of a dirty favor auctioned off in Washington, D.C., then they'll be more reluctant, or at least give a second thought to turning the entire system over to that bunch of criminals that has caused everything we see. And what we see is a bashing of consultants, and a bashing of hospitals, and a bashing of insurance companies, and a bashing of physicians as price gougers, greedy, capitalistic pigs. And there's a lot of beating that is deserved. No question about it. There are plenty of beatings that need to go around that have not yet made it around. But the primary conspirator in this mess is the federal government. I tell people that whatever the crime has been committed in this medical industry, know that Uncle Sam is driving the getaway car. They are involved in so deeply in the way the system runs to the dissatisfaction of the American people. So more government involvement, I think, is not indicated. And I say what we see as a failure of the system is not a failure of the free market. It's an absence of the free market.
Yeah.
Because the free market viciously punishes people who price gouge and don't deliver value. So I am an optimist. I'm a long-term optimist, and I'm a short-term pessimist.
Okay.
And I think things are bad. I think they're almost bad enough to tip the scales and send it another direction. I don't think they're bad enough yet.
Okay.
I think we're close, though. If I'm looking in my crystal ball, I think it happens during my career and in my lifetime. I think it's that close. So I would say inside of 10 or 15 years, definitely we will see a wild shift in the way medical services are delivered and financed in this country. Inside 1 of 2 years, I wouldn't rule that out.
Right. Well, and so then what if not government, which I'm in agreement with you there, definitely don't want more involvement. If not that, then what is the replacement, or what is the improvement in efficiency in the healthcare?
And I have dabbled in nibbling around the edges of this disgusting cesspool of a system that we have, and trying to reform it or make it better. And that's the revolutionary in me that wants to step in and kind of take it over and change it. And I'm older and wiser now, and I see myself as more of a rebel.
Okay.
Having seceded from that system and creating an alternate path.
Okay.
And to the extent that buyers step off of the Titanic and decide to buy from an alternate path, which is providing upfront pricing, value pricing, better outcomes, to the extent that that happens, no revolution need take place. It will just simply wither and die.
Okay.
Like a bad restaurant serving poisonous food. It just cannot stand scrutiny or competition.
Right.
So I envision a market economy for medical services that subscribes to the same market discipline every other industry in this country must endure. And if you're not any good at what you do, you go out of business.
Right.
And if you're great at what you do and you're fairly priced, then you're really busy. And that's the American way. You know, that's capitalism. It's a beautiful thing. People that think that the market discipline and capitalism do not belong in this industry, I think are really thinking wrongly.
Yeah.
There will always be an imbalance of the supply of services and the demand for them. And so, you know, pick your brand of how you want to match those up. Is it a bureaucrat that is rationing with the resource-based relative value scale price controls? How's that worked out for us? You know, so do you want a bureaucrat who is subject to all manner of political and bribery sort of influences, or do you want the mechanism that has made this country great and any other country that's embraced it? Do you want the market economy, which brings us efficiencies that we can't even envision now?
Yeah.
If it's allowed to work, and I vote for the other.
Yeah, I vote for the latter as well. What you're almost describing is a parallel healthcare economy, effectively. I don't know if if you've heard of the social media platform Gab, which was much derided, and because they were radically in favor of free speech, and that wasn't very cool the last couple of years.
Right.
But the leader of that company, Andrew Torba, basically he had to set up his own parallel payment model, his own parallel servers, because he was poo-pooed by Silicon Valley and they tried to destroy him. And so he had this notion of, I'm going to set up a parallel system, right? I'm not going to take that system down. I'm simply going to operate adjacent to it.
Exactly.
And leave it as an option for people to decide to participate in or not. Right. And perhaps that is what you're describing. Maybe that is the best way to do it, is if I've got two choices, and even though this one's small, but it's mighty and it seems to be a lot better, why don't I choose option B instead? And then the other one obviously will either have to respond or it'll wither and die.
And that's the basis of the Free Market Medical Association, is you have a willing buyer and a willing seller. And so if an alternate path, a parallel sort of medical universe, is better valued by the buyer, then those conditions are satisfied.
Well, I don't know if the room's telling us it's time to go, but the lights just dimmed on us the last couple minutes, so probably a good place to stop. Well, this has been a pleasure. I really appreciate you making the effort to come down here.
Yeah,
Dr. Smith, it's been great to finally get to hear your story and have it told on the podcast. So I wish you luck, man. I hope obviously this leads to some more business for you, and thanks for lending your voice to the show.
Thanks for having me.
My pleasure.